This video is going to be mostly on fluid and electrolyte imbalances. So starting at the beginning of chapter 9, pathophysiology, it talks a little bit about adaptations in cells and tissues. So atrophy when the size of your cells is decreasing, hypertrophy when the size is increasing, hyperplasia when you're actually getting an increase in the number of cells, dysplasia when the cells are becoming altered in size, shape, or organization, and then metaplasia when one type of cell is being replaced by another. And then the next part of this is disturbances in fluid balance. So we've all seen people with edema when they have excess fluid. On the flip side of that is fluid loss. So most fluid loss in healthy people is what we call isotonic fluid deficit. And what that means is that the amount of water that's lost is proportionate to the amount of sodium that's lost. So from normal things like sweating, vomiting, the loss of blood or plasma, using loop diuretics, fever, just general dehydration, that's normally going to be an isotonic fluid deficit. So we're dehydrated, we're losing fluid, but we're not going to encounter those electrolyte balances. So moving into electrolyte imbalances, there's a couple of key electrolytes here it talks about. So the first one is sodium. Your normal sodium levels are 135 to 145. The book ranges differ a little bit, but 135 to 145 is pretty standard. When you have a hypertonic fluid loss or fluid deficit, what that means is that you are losing water without a proportionate loss in sodium. So you're losing more water than you are sodium, and that results in hypernatremia. So now we have all this excess sodium in comparison to the amount of fluid in our body. So it can be caused by diabetic ketoacidosis, diabetes insipidus, high protein intake, severe diarrhea. And then on the other end of that, we have hypotonic fluid loss, fluid deficit. So what that means is that the amount of sodium that we're losing is greater than the amount of water that we're losing proportionately. So we're losing a lot of sodium compared to the water that we're losing. So all the water that we are losing is super concentrated, and that's going to result in hyponatremia, so low sodium levels. It can be caused by sweating, vomiting, diarrhea, thiazide diuretic use, heart failure, cirrhosis, or renal failure. Because now we have an excess of fluid, those things are also going to cause hyponatremia. So even though we're not losing fluid, we're adding more fluid, so that fluid is now less concentrated, which leads to those lower sodium levels. The next electrolyte that it talks about is potassium. Normal potassium level is somewhere around 3.5 to 5.2. Potassium mostly lives in your cells. It enters your cells or exits your cells based on your insulin levels, whether your body is secreting insulin or not. It has a lot to do with your muscle function. So low sodium, high sodium levels, you're going to get a lot of effects on your muscles, your cardiac muscles. We're going to start to see changes on an EKG. Regulates our acid-base balance a lot. And it goes kind of hand in hand with a lot of other electrolytes. So if our potassium levels are out of whack, it starts affecting other electrolyte levels. So hypokalemia, low potassium, is often from a decreased shift of potassium into the cells as a result of insulin administration. So you'll see people in the hospital whenever they're on an insulin drip, they're also normally receiving potassium. It could also be from renal potassium loss or decreased dietary potassium intake. And then hyperkalemia, elevated potassium, is from decreased excretion. So our kidneys just aren't getting rid of that potassium properly, or shifts of potassium from within the cell to outside the cell, such as in burns, crush injuries, metabolic acidosis, and insulin deficiency. Calcium is going to be the next one. It's essential for muscle contraction, blood clotting, nerve impulse transmission, and has to do with a lot of hormones and chemical secretion. So a normal calcium level is 8.8 to 10.3 milligrams per deciliter. So decreased calcium or hypocalcemia can be due to decreased calcium intake or absorption. So vitamin D deficiency is a pretty common cause. Endocrine disease and sepsis. And then hypercalcemia can be from increased calcium intake, cancers, endocrine disorders, and things like that. Next is magnesium. Normal levels are 1.6 to 2.4 milliequivalent per liter. So low magnesium can be from decreased absorption or intake, increased renal loss, increased GI loss from diarrhea, vomiting, celiac disease, or IBS, things like that. And then high magnesium levels or hypermagnesemia is increased from usually kidney insufficiency. So your body's just not getting rid of it like it should. And all those things typically lead into acid-base balance disturbances, which Crystal touched on, I believe, in a different video. It also talks a little bit about phosphate, which is primarily intercellular, but it's an anion, so it has a negative charge, unlike all of the others that we just talked about. It's essential for the formation of bone and teeth, cellular energy metabolism, pH, muscle and nerve function. So that also plays a little bit into that acid-base balance within the body.